So, good morning, everybody. I'm Paola Mead, the Secretary for Mission Brain. I'm very excited to welcome you all to our series of scholar lectures. So, the intent of these lectures is to showcase basically the work that all our scholars have been doing for the last 3, 4 years around the globe. We're very excited to have 3 different scholarship programs that have been very, very successful in Mission Brain. And now our goal is to create this lecture series that will be recorded and then later uploaded to our website for everybody to see all the amazing work that our scholars have been doing. They are amazing. They reach out to Mission Brain already with a project in mind. Some of them, like Dr. Steele today, they already have a career in global neurosurgery, and they reach out to Mission Brain because they want us to be part of what they're already doing, which is very exciting. So today I have the pleasure and the honor to introduce one of our first Lisa Hannigan scholars, Dr. Megan Steele. She graduated from neurosurgery residency at the University of Florida. And since the beginning of her neurosurgical journey, she has been spearheading like a lot of projects in global neurosurgery. One of them being the capacity building in Sierra Leone along with Mission Brain. So welcome, Dr. Steele. We're very excited to have you and to learn from you today.
Thank you so much. Can everyone hear me okay?
Yes, we can.
My computer's functioning. Excellent. All right. Well, yeah, thank you for having me today. I'm really excited to share some of our data and just kind of explain a little bit about what we've been doing in Sierra Leone for the past several years. So I titled this very blandly Establishing Neurosurgical Need, in Sierra Leone. But really what I'm going to talk about is kind of the overall project that we've been working on with the Ministry of Health, the WFNS, and Mission Brain for the last 3-ish years now, and continuing to move forward past my time as a Lisa Hannigan scholar. I'm hoping this goes away at some point up top. I don't know how to make it go away. I apologize. All right. Well, as a brief introduction, I'm assuming most people who are here kind of know the basics of global neurosurgery and the need in the world, but just as sort of a very basic introduction to kind of the context that we're working in Africa, there is approximately 1% of the world's neurosurgeon with at least 15% of the neurosurgical burden of disease. Probably more than that, but that's at least what we have documented in the literature, and a very, very high proportion of pediatric population compared to other regions of the world. And so the population that we're looking at is younger than average, and a lot of times still in the developing stages, or they're the young working people supporting their families, the people that we're talking about who are injured and having neurosurgical conditions. And of course, the public health impact of things like traumatic brain injury and other neurosurgical conditions extends far beyond the immediate injury. But the things that we care about and want to prevent and prevent secondary injury, to prevent things like long-term cognitive deficits, developmental delays, behavioral changes, especially in the young population. And then, of course, there's the downstream effects of the financial strains on the family, the economy, the healthcare systems, and the healthcare growth as a whole. Excuse me. So for Sierra Leone specifically, it's a West African country along the coast. It's very small landmass, but hosts a population of about 8.5 million people. It was originally utilized as a home for returned slaves in the 18th and 19th centuries, which is why the capital is called Freetown, is the land of the freed people, essentially. It is currently ranked as the 4th poorest country in the world based on GDP per capita, which is about $433. And as far as the healthcare system, it's kind of I guess, a centralized system in that there's these peripheral healthcare units out in the provinces with the extended community healthcare programs. And then there's 21 district hospitals that those healthcare units can feed into, and the 3 primary referral hospitals, of which one major one, the tertiary kind of trauma referral center, and the primary academic center is Connaught Hospital, where we worked And then there's 45 private clinics and 27 private hospitals throughout the country, many of which are centered in Freetown, but there's several located all throughout the provinces as well. And then I guess I don't have it specifically listed on this slide, but there's only one real medical system or one real medical school in the country, and most of the surgical training is done at the primary tertiary trauma center at Connaught Hospital. And so, yeah, there's no neurosurgical training in the country. Connaught is the host to the surgical residencies for general surgery, for pediatric surgery, for plastic surgery, for ENT, for orthopedic surgery. But there's no current neurosurgery residency in the country at all, and not in their like healthcare system. And there is no neurosurgeon practicing in the public sector. If you ask the medical practitioners there, some of them say there are no neurosurgeons in the country, and some of them say there's sometimes I believe it is an Egyptian neurosurgeon who will practice, who has a practice in the private hospital, but it's very limited what cases he takes, and it's very high dollar. And he requires CT scans and high cost imaging modalities that a lot of patients aren't able to get. And so essentially, functionally, for the vast majority of patients, there's no accessible neurosurgeon in the country. In the current system, or at least in the system without a neurosurgeon, the orthopedic and general surgeons are the primary teams that manage the neurosurgery patients. The TBI patients tend to go to the orthopedic surgeons because they had some amount of TBI training during their surgical rotations in their residency programs. The pediatric surgeon will care for the hydrocephalus and the spina bifida pediatric patients, because in his pediatric surgery residency in Nigeria, he did neurosurgery rotations there. And so he is trained as like a task sharing mechanism of placing shunts and closing open spina bifida deformities. And so he'll manage those patients. And then other neurosurgical conditions like strokes or like mild TBIs, spine injuries, or tumors, things like that can be scattered across the hospital from the medicine service or the emergency department, who has admitting privileges, kind of wherever they fit in or wherever they felt they're appropriate. And so there's no one kind of centralized admitting service or specifically trained service for these patients. There's also no CT, MRI, or advanced imaging available in the public hospitals. Currently in Freetown, the CT and MRI machines are at the private hospitals. And so if patients need these advanced modalities, they have to be loaded up into some sort of vehicle, usually a private vehicle, transferred to that private hospital, pay cash for the image, and then come back to the public hospital where they're being cared for. If their family is able to get the cash together to pay for all of that. And then again, the CT scanners tend to be relatively unaffordable for a vast majority of the population. So one of the challenges we're facing is that even if you plopped a neurosurgeon in the middle of Connaught Hospital, that doesn't necessarily take care of the access to appropriate neurosurgical care problem that we're facing in the country. And so, you know, as a broad general umbrella goal for this entire project and the long-term partnership that we're creating, the idea is to help the Ministry of Health in Sierra Leone establish the first neurosurgery department in the public sector. And their target was to establish this department in the tertiary referral training center in Connaught Hospital, where they already have their primary surgical residencies for other surgical subspecialties. So the aims of my particular area of the project, this is as you can imagine, this is not something that we were going to get done in, a 1 year on the ground term, or by me alone by any stretch of the imagination. This has been a multidisciplinary, international, multi-person, multi-year project where we're pulling people in from nursing and anesthesia and ministry and public health sectors and education and neurosurgery and all these different teams and all these different NGOs and equipment donation and transportation. There's lots of things that goes into this. And so by no means am I in charge of all of this, and by no means am I doing all of this alone. Nor was it only over the time that I was funded by the Mission Brain Scholarship, but to kind of narrow down the specific aims of my time in country, because I used my research year in residency to spend nearly 10 months in Freetown to do some of the kind of on the ground work and data collection that we needed to sort of support some of the primary aims of this project. I broke it up into these specific aims for my time there. And then the ones I'm going to kind of focus on today are the determine the unmet burden of neurosurgical disease. So just kind of document what's coming through the hospital and how many patients are having these neurosurgical injuries that aren't being met and what's happening to them. Because it's really easy to say, okay, there's no neurosurgeon in the country and that should be fixed. But it's another thing to actually have numbers and data and information to back that up. And that really is what speaks to the public health and political sector of the people that we need to continue to speak to. And then conduct a formal needs assessment, this being of like the equipment and the personnel side of things outside of just kind of the medical context. So from just a determining needs, just an epidemiologic standpoint, we did a 5-year retrospective chart review. This is the actual chart room of the hospital. This was manually, we recruited a team of, I think we ended up with 15 medical students and early residents who were interested in neurosurgery, neurology, or just kind of public health and making their country better for their patients that had seen a lot of TBI and a lot of patients that they felt were not adequately, whose care was not adequately addressed, and just really wanted to make medicine better in their country. And not necessarily all want to be neurosurgeons, but they wanted to participate in this project. And so we worked every day in this room and went through each and every one of these charts, read them, and decided that if any of these patients had anything resembling a neurologic or neurosurgical injury, that you could imagine would require a neurosurgery consult, essentially, then we included it in the database. We did this for this room. There were 2 or 3 other rooms that looked like this. And then we went through every inpatient ward that had logbooks and looked through all the logbooks that were on paper, that were not full charts, but just kind of line by line logbooks that talked about every patient that was admitted, what they had, and their like admission and discharge dates, and kind of very brief overviews rather than detailed overviews, and included those. And we went through the morgue and we went through the emergency room. So essentially any chart we could get a hold of, we looked through and included any patient that was neurologic or neurosurgical looking. And so we ended up with a patient cohort of about nearly 3,000 patients for the 5-year retrospective review. And the purpose of this talk isn't really to go through the data, because there will be plenty of papers and plenty of talks that go through the kind of the nitty gritty of the data, what we found, and who was included and who wasn't. But the idea is just really to say there was a whole lot of data that was collected. We had a whole lot of man hours that went into this. My team of 15 spent anywhere from 3 to 7 hours every single day for 9 months straight in those hot, air-conditioned rooms, pouring through patient charts and typing it into a Google Doc form on their phones, because none of them had computers except for me, for nearly 10 months straight. And so this was a huge undertaking to get this data to present and to have a kind of essentially pre-interventional baseline and a documentation of the profound need that occurs when a large portion of the population doesn't have access to basic neurosurgical care. And so unsurprisingly, there's a large cohort of young patients. They come from all over the country. This is kind of a basic breakdown of the diagnoses. You have the symptoms, the diagnoses, where reasons for presentation. There's a whole lot of road traffic accidents. There's a fair amount of trauma. There's a fair amount of patients who present for kind of acute onset weakness, things like that. one of the things that's interesting is to note is that the vast majority of patients didn't get imaging. And so only about 20% of our cohort had their diagnosis confirmed with imaging. So about 80% of these diagnoses that you see here on the left are essentially presumed diagnoses based on clinical presentation, based on symptoms, based on the context in which they presented, and not necessarily imaging confirmed. Which, if any of you are, practicing neurosurgeons or practitioners in this in the U.S. context, that would be immensely frustrating to us, and we tend to not even necessarily accept neurosurgical consults without imaging showing that there's a neurosurgical problem. And so it's a very, very different context to try to practice surgery or surgical skills in. And then an important thing to note on this slide is that there's a nearly 20% mortality rate and a less than 20% follow-up rate. And so this really shows just kind of the general challenges in which we're trying to establish a new surgical department in the context of travel challenges and imaging challenges and financial challenges, and things that I think are seen in a whole lot of contexts that people work in global neurosurgery. So I could talk about this data forever. Those are certainly not the only data points we collected in that database. We have many, many, many more, but those are just sort of summary tables. But the overall themes are the lack of definitive diagnosis. Obviously, there's a delayed presentation for a lot of patients, somewhat because there's not a lot of public education either for the public or the clinicians about neurosurgical problems, or because of traditional medicine being used first, or because of going to provincial clinics like the community clinics or the provincial hospitals first before being transferred to the tertiary referral hospital, which is of course an appropriate pathway to get to a tertiary referral center. But in a neurosurgical context, in a location without emergency services such as ambulances or ways of ambulances or helicopters or things that can make urgent transfers very rapid, can be devastating and lead to devastating long-term neurologic consequences. We noticed a severe lack of medications in the hospital, so we did our very best to attempt to document not only what medications were prescribed, but then what medications were actually given. And there was a lot of times where the medications were prescribed things like BID, and then they'd be given, in the morning on Tuesday, and then the evening on Thursday, and then in the morning on Saturday, and then never again, because those were the times where the families could get together enough money to get those medications from some pharmacy someplace in town. And the actual pharmacy in the hospital frequently would only have things like 2 or 3 antibiotics and Tylenol. They, at least when I was there, didn't host things like Keppra or any anti-epileptics, or sometimes they had mannitol, but not 3%, and things that we think of as standard of care for TBI, at the very least, management. Other things we noticed was that every single patient essentially got antibiotics, which I discussed at great length with a lot of the practitioners there, and I understand the reasons why, and I think it's reasonable, but I have concerns that in the future, and especially for going forward with surgical interventions, that there's going to be a lot of antibiotic resistance if every single patient who walks through the door gets antibiotics. And so that's going to be something that we'll have to look at moving forward when we're starting to do more interventions. And then, of course, the high hospital mortality rate and follow-up. A secondary thing we looked at was the needs assessment. So the way I kind of did this in a standardized fashion was the PIPES assessment. So the surgeons overseas several years ago was an NGO, I think, that made this sort of generalized assessment that essentially evaluated the readiness of a hospital for surgical intervention. And this is a picture of kind of the overview of their PIPES assessment tool. It looks at personnel. It has 4 kind of primary things. It has personnel, infrastructure, equipment, and I can't remember the 4th aspect. I apologize off the top of my head, but essentially these are kind of yes or no questions that asks like, do you have this instrument, X instrument, running water, incinerator, like a blood bank, yes or no. And it's not just a yes or no, but it's, you have it adequately. So do you have it always available or not always available? And then, oh, the fourth one is surgical procedures. So they listed basic surgical procedures that they think that one should do for essentially a basic emergency hospital. And can you do this procedure? And that's a yes or no. And so we did this pipes assessment in Connaught, but also in six total major hospitals in Connaught, to compare the government hospital, the private hospitals, like the private hospitals and the NGO hospitals, and kind of see like across the board the readiness for surgery of a bunch of the hospitals in town, and then also maybe where some of the personnel or equipment strengths lies. So that way, instead of reinventing the wheel and having to kind of bring everything to Connaught in a new way, maybe we could pool resources that already exist in the community and figure out ways to strengthen the neurosurgery system in the city without having to bring in a whole bunch of new stuff if it already existed. The pipes assessment since this original iteration has been there's been a several new ones that have been published, including a PD pipe. So one specifically focused on pediatric surgery, and then one published by the DGNN Duke group for neuropipes, specifically focusing on neurosurgery. And so we did a pipes, a PD pipes, and a neuropipes at all six of these institutions. This is a whole lot of numbers and a whole lot of data. But the purpose that I'm not going to go over essentially, but these are all six hospitals, and really the purpose is these were some of the neurosurgical procedures that I chose just to kind of highlight here. You can see there's a whole lot of zeros, so essentially nothing in the entire city is prepared for things like ETVs, EVDs, myelo repairs, craniotomies, like every single hospital in the whole city said zeros to all of those things. We had no spine, no hospital in the city that said they felt equipped to do spine surgery, but then like skin grafts, the one that did the Connaught where they have plastics said they can do it. And then the anesthesia services are actually a lot more robust around town than the surgical services. And so this kind of shows you the difference between, like, this is sort of the neuropipes focused. Ooh, dear goodness, sorry. No. This is the neuropipes focus kind of here in the middle where you see all these zeros, and then up here where you see a lot of ones. These are kind of basic general surgery things, resuscitation, suturing, wound debridement, those sorts of things. And so the point here is the contrast between kind of general surgery and surgical procedures, and the fact that there is surgical possibilities here, and the fact that no one has focused on neurosurgery yet, and with the idea that, okay, no, maybe we're not crazy for just focusing on Connaught, and we're not reinventing the wheel in this country, but it's actually, this is a reasonable and adequate place to start the department. And then this is, again, kind of an overview of the hospitals we looked at. So we have the government, the private, the NGO, the combined. And this just looks at the number of beds, the total beds, and sort of the overall total pipe scores of every one of them. And the thing to highlight here is just that the Connaught kind of lists on the lower end of some of the hospitals in the city, which is not necessarily surprising given that we already discussed the fact that the private hospitals have a little bit more access to equipment because they're privately funded. And you can see that kind of the government hospitals are on the lower end of these things, but of the government hospitals, the Connaught is the highest prepared from a surgery standpoint of all the publicly funded hospitals and ministry supported hospitals in the city. So again, it sort of supports our idea that Connaught is a reasonable place to start this, but also that there's not a whole lot of equipment or personnel or things that we can be pulling from these other hospitals at this point to try to support our efforts. So total from data collection, some of kind of our main conclusions is that we have a lot of limitations to what we could find in the written charts. We basically wrote everything we could find down, but there's still a lot of gaps in our data, which is a challenge with retrospective paper written chart reviews, which is why we're also working on prospective data collection. We have about a third of patients who are evaluated elsewhere prior to transfer to our tertiary referral hospital, which is a major point of intervention from a neurosurgical standpoint, because time is brain and time is spine, and so these are things that are really important to know from a public health standpoint when discussing things with the ministry, things like road traffic safety, ambulances, EMS systems, referral patterns, education of ED doctors and other surgeons to call the neurosurgeons faster once the department exists. All those things are going to be imperative training um, for upscaling of medical and surgical service delivery in the country rather than just plopping a neurosurgeon in the hospital and saying, here I am. Like there's a lot more that goes into it, especially when you have a large volume of patients that are transferred. Um, Less than 1 in 5 patients has a confirmed diagnosis, which is a whole other can of worms that we're working on. And then the follow-up and limited equipment and personnel readiness are things that we've kind of already discussed. And again, none of this is surprising, like none of this is revelatory. And I think all of this was expected, but the purpose of this was really just to have hard facts and hard data to take with us to meetings with the ministry and the UN, the WHO. Anytime you're kind of in rooms with policymakers and people who go on facts and data, number and money, this sort of data is really important to bring to the table with you, rather than just saying, well, there are no neurosurgeons and there need to be neurosurgeons because people need neurosurgeons. And so that was the primary purpose of my time in the hospital from a data collection standpoint. Obviously, there are limitations when you're doing a retrospective chart review on the ground, when no one expected you to do this, because they weren't writing these charts for data collection and research purposes. They were writing these charts for patient safety at the time purposes. And so lots of blank missing data. Data is limited to whatever people decided was necessary at the time. And so there's no standardized data collection. They're literally just like blank pieces of paper that practitioners can write in whatever they need. And so it's not like our EMRs that have required sections that you have to fill in to be able for billing or for admitting purposes or what have you. It's whatever someone thinks to write down. And then the primary pediatric hospital and all the imaging, of course, is across town. And so from like a ped standpoint, we're not necessarily getting all the pediatric patients because those go to the pediatric hospital. We only get the patients who need pediatric surgery. And so some of our pediatric evaluations are fairly limited. So that really was a lot of talking about just like data. And that was kind of what I wrote down. So when I was writing grants and writing grant applications and trying to get myself in country to do some of this on the ground work to support this project, during my research year, you really needed like a data-driven reason to be there, to get money from, NIH or Fulbright or Mission Brain, like those kinds of things need a research. And so that was my research project and my research purpose. And that was really the primary purpose of that, was to document the need, to keep encouraging engagement by the Ministry of Health and other international partners to really engage in this upscaling project. But from my own personal side and also from the kind of project as a whole side, obviously documentation of need was not the primary underlying goal of this project as a whole. The underlying goal was to get a neurosurgery department started, and that doesn't come with just data. And so while I was there, I was also doing other stuff like identify areas of primary focus for the current department for future interventions. I was trying to get equipment donated and set up and into the hospital, getting the operating room set up. With April and a whole bunch of people at Mission Brain and other partners, we were doing nursing training and medical student and resident training. And then one of the primary things I personally worked on myself every day when I was there and really wanted to focus on was engagement with and mentorship of the local trainees. So medical students, residents, about neurosurgery and even nursing staff, like making everyone feel prepared for having this new department dropped on them, because neurosurgery feels really scary and overwhelming if you're not educated in it. And I think just saying, hey, we're going to have neurosurgery patients here and post-op patients here, without any training or without any preparation feels overwhelming to people who have not had to manage these patients before. And so part of my goal was to engage with the practitioners there and prepare and educate and really help kind of make this a better transition. And so to that end, I did stuff like give regular talks to my research team and to any medical student who wanted to join. We did regular neurosurgery in a nutshell talks where we just kind of went over neurosurgery and neurology clinical aspects of things, how to do a neuro exam, what are reflexes, motor exams, how you should approach a patient in the ED, basic diagnoses, clinical pathways, whatever they asked me for. We had neurosurgery in a nutshell chats on a regular basis. In their morning teaching rounds, they have morning meetings essentially every morning before the surgery residents have morning meeting where they do a morning lecture, but also kind of rounds. So both it's a teaching rounds and also morning meeting. So I would give lectures, how to read a CT scan. I gave a preliminary review of our trauma registry data, talks about how to write your first research paper, kind of how to approach the blank page when you have a research question. We designed in conjunction with myself, the anesthesiologists there, the orthopedic surgeons there who are already taking care of neurosurgery patients, the surgeons and the A&E doctors there. We designed spine trauma and TBI treatment pathways that were reasonable for them to implement, like read through and implement, and for a management pathway. So this is essentially taking like the Brain Trauma Foundation guidelines, but then kind of breaking it down into what's actually available and manageable at their hospital, because obviously all the medications and all the kind of higher end like ICP wires and monitoring and those sorts of things aren't available there. And so we can't print out Brain Trauma Foundation guidelines and hang it on the wall. So we edited those to what's available and manageable for their context. And so we ran these pathways past everybody who's engaged in the ICU doctors, the ICU nurses, the heads of the nursing staff in the perioperative pool, all those, like everybody who's engaged in caring for the TBI and trauma patients, and got approval from everyone. So then printed these out on very large paper and hung them in all the wards and all the walls and all the ICUs, and did teaching with the residents and medical students and nursing about these trauma pathways to try to get better standardized care for neurotrauma. And then of course, continuing to work with our data, we're putting together papers and abstracts with the team there. And really what I'm trying to point out with this is not only the success of getting some of these submitted over the past couple of years, but more importantly, the fact that all of these are being written primarily by the Sierra Leone team. They're the first authors on all these papers. They're the first authors on all these abstracts. They're presenting their data at medical student research days and presentation days in Sierra Leone, and they unfortunately have not been able to travel to the US to present them at places like CNS and AANS, and so I've been representing our team there. But we've just been continuing to talk about this and work on these and spread this information for the past year and a half, I guess, since I've been back. And have obviously several manuscripts in the works as well. Again, we're the teams there who were the primary data collectors and are the primary authors on the paper. Similarly, we have recently established a team with the Mission Brain newly developed Global Neurosurgery Research Group that's kind of helping to spearhead and take some of this data and move it forward also. So the Sierra Leone research team of the GNRG is helping to get some of this across the finish line, and also take some of the data that we have and haven't used with the team in Sierra Leone, and take some of the excuse me, some of the database data that we have that hasn't been written up yet, and kind of make some new papers out of that. And so we have a working group that's moving this forward and continuing on, and we're kind of combining some of the Mission Brain research team people with the Sierra Leone research team that I created and led back when I was in country, and not necessarily part of the leadership team on Mission Brain. And so we're combining forces and working with the Sierra Leone chapter of Mission Brain to really continue our partnership continue to make this data collection meaningful, and then also hopefully in the future, again, use this data for implementation purposes. So public health interventions, things like helmet use, road traffic safety. We're working with the Ministry of Nutrition to work on folic acid fortification of rice and cooking oil there for spina bifida prevention, and really moving towards a lot of implementation and using this data to support public health interventions in the future, and then using the GNRG to kind of evaluate the effectiveness of these interventions would be my overall goal for this team going forward. I feel like I got ahead of myself and said some of these things already, but we want to keep using this data, publishing, analyzing. I do still meet with my team every month to talk about the papers that we have ongoing, but also just continue to talk about research in general. They do not have a very robust research training throughout medical school, and a lot of them actually are interested in research. Several of them have applied for certificates or master's degrees in research or biomedical research or public health or global health. And so or statistical analysis. And so they're actually really interested in doing more research in their own context, whether it's neurosurgical or not. Most of them don't want to be neurosurgeons, but they do want to be researchers or scientists and help move the needle forward in their home countries. And so we still meet and talk about research and publications and how to do that kind of in a broad context every month, because they don't feel like they have a lot of mentorship for that at home. And then with April, this is really April spearheading this, but completing the nursing training for neuro nurses in Sierra Leone. And then I think we've tried to kind of come down on a plan for a biannual mission brain trip for continued support of kind of the clinical on the ground work that's been happening there. We're still working on getting some major equipment purchase and transportation stuff for the clinicians that are working there. And then one of the things that we really like to do is get some neurosurgery registrars, attendings, rotating through the department once it's kind of more established and ongoing for mentorship for the new practitioners. And I guess I should say that the first neurosurgical trained Sierra Leonean surgeon started practicing in the department back in February or March, so earlier this year. He is not a full-fledged neurosurgeon. He did about half a neurosurgery residency to focus on neurotrauma. So he does essentially only trauma and spine, like brain trauma and spine fractures, because he's an orthopedic surgeon. So he is already a surgeon, and so he just did some neuro training so that he was comfortable doing those cases. And then the first fully trained neurosurgeon will return home to Connaught by the end of 2026, I believe it's supposed to be. And so we're nearing having a fully trained neurosurgeon and a second trauma neurosurgeon by the end of next year. And so really getting this department more robust from an equipment and a mentorship standpoint is what we're focusing on in the next 18 months. And as I said, public health interventions. So I think overall we've demonstrated that there's a high incidence of neurosurgical disease. There's probably a lot of underreporting due to the that we have in at least our database due to the paper charts that we were encountering. But there is obviously a need for an improved emergency and neurosurgical care in the country. And we're hoping to use the data we have here and kind of the work and partnerships we formed to inform policy changes and targeted public health interventions to improve patient safety in the country. And I feel like I just talked a lot for the last 45 minutes. I'm sorry, I was hoping to finish a little faster, but really none of this could have happened without our team in Sierra Leone. These are the primary movers, the people who spent, as I said, many untold hours in the chart rooms and since writing the papers, writing the manuscripts on Zoom with me monthly since for more than a year. On WhatsApp, never ending. And the people who are really very dedicated to improving neurosurgical and healthcare overall in Sierra Leone. And so we couldn't have done it without them. And several of these doctors are actually the Mission Brain leadership team in Sierra Leone for the Mission Brain chapter there now as well. I think that's all I have for everybody. I'd be happy to take any questions, but I appreciate the opportunity to share our work today.
Thank you so much, Megan. I think this is wonderful. And I know you're powering through an illness. So we really appreciate you being here with us this morning. I think before I think we move forward, there are several questions here. I think our board member, illustrious Dr. Bartholomew is here, and I'm so happy he's here. There's a bunch of questions from him. But before we move on with that, I would actually like to acknowledge all those from the Sierra Leone chapter to please raise your hand so we can acknowledge you. And I know a bunch of them are here. Ahmed is here from what I can see on my screen. So if you don't mind raising your hands, that would be awesome. Don't know if they can hear us.
Let me see.
Yeah.
Ahmed for sure.
Alpha is here. I don't know who else is here. But thank you all so much. There's a few questions here. I'd also like to acknowledge Dr. Victor Garcia Navarro, another board member who's here today. Good morning. And Dr. Gabriel Vargas Grau is also here with us. So wonderful to have all of you here. And I will go on with the questions. There's a few questions. Ernest, would you like to just unmute and ask your question to Megan?
Sure. Very, very exciting work, and it reminds me a lot of similar work I did in Haiti under very similar circumstances in 2011. So in terms of TBI, what is the, you had TBI sort of subdivided, and I might recommend putting those together when you're ready to submit this, and saying TBI as an overall category, and then here's each of the TBI subcategories. But are your subcategories, are these diagnoses exclusive or are they overlapping? And how much TBI was there in total?
Yeah, they're overlapping. This is a very broad overview. And I think where we're publishing, we have a paper that's like exclusively TBI, and then going to be exclusively, Pete's TBI, and get more in the nitty gritty. I don't think we're going to publish a paper that just has this because it's too much and too broad and too non-specific. But they're not exclusive. So the ones that have, ICH probably have some TBI, or also have a diagnosis of TBI in there too. So these numbers don't add up to 100 by any means. The mild, moderate, and severe got categorized as best I could for any patient that did have a GCS or clinical evaluation at first that we could diagnose with, or we could give them a GCS, like anything that was written down with their first evaluation, their first physical exam, that one could find a GCS. But there was plenty of patients in the charts that didn't have an adequate documented first physical exam for an admission GCS, and so like those patients don't have a GCS for their initial TBI, and so they were potentially put under undefined TBI or head injury. And then some of the other ones like subarachnoid hemorrhage or intracranial hemorrhage, those sorts of things, sometimes were subdural, sometimes those were suspected but not confirmed because of lack of imaging. So by no means are these exclusive.
Okay. And that was part of another question. I don't know if just to speak, if I'm speaking out of turn, if anybody else has other questions, but I missed the first few minutes, came in a little bit late. So just wanted to understand the imaging context of these diagnoses. And part of that is the stroke all clinical diagnosis, which is what I had to do in Haiti also in 2011.
Yeah, a majority of the stroke is clinical diagnosis. So at our stroke paper, I think it was like 76% were clinical diagnosis. They came in with, things like hemiparesis and drooling, or, hemiparesis and facial weakness and aphasia. But then if they didn't get the imaging that was ordered, but were treated as a stroke, or came in with hypertension and hemiparesis. And so all these diagnoses were done manually by me. There's actually a whole other talk I could give, but I tried to use AI to teach in an iterative fashion it to go through this data and give a diagnosis based on all these rules I gave it. You know, if it says these and these and these things, then give it these diagnosis, and it just failed miserably. And so I went through all of these manually, every single exam that we had documented in every single clinical context, and gave them my own diagnosis personally. And so it is based on what was documented clinically from the exam, the context, you know, whether they got in a car crash or were found at home weak, you know, played into the fact of whether they were diagnosed as a brain injury or a stroke in the absence of imaging, sort of thing. And so that's a big part of it too, for sure.
Last question. Do you know whether it was a house officer or practicing physician that documented the diagnosis you were reading from your paper charts?
Most of them were house officers. There's a couple of them who were last year medical students, because it was a team of 15 of them. And so they were copying, you know, we did a whole bunch of training together, this team and I was there every day that they were doing.
I'm sorry. Let me clarify. Let me clarify my question. What I mean is, do you know who documented the diagnosis before you started your research study?
Oh, like who wrote it in the paper chart?
Mm-hmm.
It's usually a house officer. Yeah.
Okay. Thank you.
Yeah.
Very important work.
Great. Thank you so much. And any questions, comments from any of our audience? I also would just like to add that Peter Bangura, who's training in Morocco right now, actually, it'll be a little bit later before he comes back. He's probably got about maybe 3-4 years more to go before he goes back to Sierra Leone.
Did I do my math wrong? So, sorry.
Time goes by. But yeah. So we did a trip a month or so ago, and I think that was one of the things that we discussed. Oh, Boris from one of our winners from our hackathon from last year. Please, yeah, go ahead, ask your question. You're muted. Boris, I think you're muted.
Okay, sorry. Thank you very much. That was a very good one. And I say hello to everyone also. So I have one question. In your presentation, I don't know, but you talk about there is no medical school. I don't know if it's in the Freetown, the capital city, or is maybe in another town. Just
Yeah,
want to
sorry,
confirm.
there is one medical school in Freetown. Yeah.
Oh, okay,
Yeah,
nice.
just no
And
neurosurgery residency.
okay, no surgeon residency. Okay,
Yeah.
okay, nice.
But there is one medical school.
Okay. And the second one was about a neurosurgeon in public hospital. So that means that there is neurosurgeon in the private hospital or not?
That's debatable. So my understanding is there's a part-time private neurosurgeon from, I believe it's Egypt, who practices there sometimes in one of the private hospitals, but he's very limited on which cases he'll accept and charges a very high rate, is what I'm told. But my understanding was he wasn't there when I was there, so I never got to meet him. And there were some people who told me he wasn't actually a neurosurgeon, that he did neurosurgery procedures, but he actually wasn't a trained neurosurgeon. And then some people told me he was, and so it's unclear, but certainly not a full-time practicing neurosurgeon.
Nice. And my last question is for Madam Mrs. April about the training of nurse. You said nurse training. The first thing is why you just focus on the nurse and not the medical student also. And the second thing is what is the plan for how many long do you plan to train this nurse? So that's my last question.
Great. So the plan is to create a team for the practicing neurosurgeon, right? So that includes the nurses. We also tried to connect their anesthesia team with some of our neuroanesthesia network that we have. But the nurses are essential in being able to take care of the patients in the OR during surgery, pre-op and post-op. So what we found when we were there, the biggest challenge was actually post-op care. And this is done in great part by the nurses. So that's why we focused on that. So really the medical team, the healthcare providers in the hospital were a priority.
Okay, okay,
And
nice.
what
Thank you
was
very much.
The medical students do rotations with the surgeon. So there's like there's a medical student who rotates with the current neurotrauma doctor, you know, who will learn from him, and he participates in the morning teaching rounds at 7 a.m. and because all of the surgeons, like the plastic surgeon, the pediatric surgeon, and the ortho surgeon, and go to morning teaching rounds for all the medical students who are on their surgery rotation, and talk about the patients and the surgeries that are happening that day and give lectures and things like that. And so the medical students' education is very much wrapped into their surgical rotations. And so what we were trying to make sure is that we didn't exclude all the non-primary medical people who are essential for patient care.
Oh, okay.
Right.
Nice. Oh, thank you very much.
You're very welcome. I think that's a good question because if you're looking at a system, you have to look at the entire system, right? Not just the physicians, the medical students, you know, the part of the challenge, even with Dr. Kamara, who's practicing there now, is that they're rotated a lot. And because there is no neurosurgery training program in the country, there are no specific medical students. It's very challenging for them to even think about going that route, knowing that the path forward is going to be extremely difficult. And we're trying to
Yes.
that up, but we're not quite there yet. So yeah,
Okay.
thank you.
I understand. Thank you very much.
Dr. Grau, would you like to unmute and ask your question?
This is me, Vargas Grau. Hello.
Yes.
Congratulations for your work and for your diagnosis of the situation in Sierra Leone. Maybe I missed the answer. That's why I'm asking the question. How difficult is to get at least a CT machine for diagnosis at this time? What would be the problem in order to have that kind of diagnostic machine? Because of course I see that you use a lot of clinical skills and things like that, but we know that we need at least a CT image in order to have a good diagnosis. So, and there is many available, maybe not the good ones, but at least something that can help to the people there. How difficult is to get one of those for Sierra Leone?
Yeah, no, that's a great question. That's absolutely something we've been working on with the Ministry of Health since long before I went there. That's one of the primary things that was a #1 focus from the onset of this project. Some of it is, to be perfectly honest, politically driven, in that we had reached out to several partners that we have through kind of the WFNS, and just working through several other people that we know who have done this in other places, and reached out for options. And the Ministry of Health partners that I have spoken to were not interested in utilizing those resources because they had their own, and they kind of had their own channels that they felt that they needed to work through for whatever it is their reasons were. And so they felt very strongly that they needed to manage that aspect on their own, at least in talking with me. But that was kind of what was communicated to me. That being said, they have been working on that. And the last time we met, April, correct me if I'm wrong, but they said they had signed a contract for the installation of a CT scanner. The installation time has been pushed back on us a couple times, but I was told last time that a contract has been signed, so it's definitely something we continue to work with them on.
Yeah. So if I could give an update on that. So Dr. Vargas, I think that one of the roles of Mission Brain in this collaboration really has been to also help advocate. A lot of times, I think what we've found, and we're really trying to use Sierra Leone in a sense that it's a good learning experience for us as well to be able to translate that perhaps to other countries with similar situations. But our partners in Sierra Leone, the Ministry of Health and the University of Sierra Leone teaching hospitals, also have to sort of learn about what some of the importance are of some of these infrastructure to be able to build a neurosurgical capacity, because it's something that's obviously in theory they understand, but in practice it's a little bit different. So because with Megan and the other people from Dr. Tariq Khan and Dr. Key Park, we've been trying to nudge them in that direction, and they are actually building the building that will house the CT scanner. And I've been told that they have fully paid for the CT scanner already. So it's a slow progress, as I think all of us are aware of when it comes to bureaucracy, but part of our goal and our role as a nonprofit institution engaging with a private-public relationship is to nudge them in that direction. And I think that we're making a lot of headway. So officially, the Ministry of Health and the University of Sierra Leone Teaching Hospital officially launched neurosurgical services in Sierra Leone when we were there last month. Also because now they really are having this CT scanner that they can talk about, that the government can claim as a milestone. It's the first one in the Kunat Hospital. There's a CT scanner in the private hospital that patients can have access to if you have the money. But yeah, so this is a big milestone for the country to have that.
Thank you.
Thank you. Any other questions from anyone? I think there was a question here, and then Dr. Bartholomew answered it on the chat. Any other questions or comments? From our chapter members in Sierra Leone, anyone want to say something? Ahmed? Alpha? Also, just to let everyone know who's interested in research, Megan touched on research training. There's a research peer mentorship program going on right now, and Diana Ochoa is in the meeting. And if you'd like to reach out to her, and Nikki Perez and Hector Cure are the ones who are heading that, they would be more than happy to see how they can provide that training.
Well, if Ahmed and Alpha don't want to talk, I would just want to say thanks to them again. They were two primary, key leaders on our team there, and I absolutely could not have done we could not have done any of this work without them. Those two took on a huge leadership role, both for me in facilitating gathering our team and keeping it going and doing a lot of translating and work in areas that I couldn't get to, and also keeping stuff going when I wasn't there and when I was sick, and now when I'm gone. I mean, these guys are amazing, and we're really, really lucky to have them on our team.
Also, I think there's also information here. Garrett Trash is also here. Him and Ali Azan are both co-chairs for the Global Neurosurgery Research Group. As Megan mentioned, there is a group that's being designated for that. Alpha is part of it. Ahmed, I think, is part of it as well in terms of doing research in Sierra Leone. So if you're interested, and if you're interested in other forms of research in global neurosurgery, please feel free to reach out to them. Victor, do you have any comment you'd like to make? I'm putting you on the spot.
Yes, just to tell you that this is really inspiring for us, and congratulations for all this effort. I think that we need to replicate this not only in Sierra Leone, in other chapters, and inspire all these people and share all the knowledge and the experience that you have, so we can replicate in other parts of the world. Just congratulations. It's a big, big effort and amazing job. Thanks for sharing.
Thanks.
Right. If there's nothing else, this is your perfect opportunity. You have experts here. Dr. Bartholomew is also a leading expert in TBI. Dr. Garcia Navarro's here. Dr. Vargas is here. If you have no more questions, I'd like to really thank Megan for showing up today, despite, struggling with her illness. But also to congratulate her. She's been really working hard advocating for the work in Sierra Leone, not even beyond after her scholarship and her research that was done there. And also thank you for our chapters in Sierra Leone and all those who are involved in research, Garrett and his team, and Diana and everyone else here. JP, Brooke, thank you. Paula, thank you so much. And I think that's it. Have a great rest of your day, everyone. Just to remind you, this is our lecture series. There's more to come, and if you're interested in more Sierra Leonean updates, we are actually featuring the two scholars for Sierra Leone. Dr. Camara, Alio Camara will be speaking as well, and Dr. Peter Bangura, who's currently still at Rabat, Morocco training, is also going to be giving a lecture. So keep an eye out for that. We hope to see you all again soon for the next lecture series.